So I was wrongly diagnosed actually in the year of 2012. Actually, it was a misdiagnosed, and my TB journey, which I have suffered, it approximately 8 years.
That was Meera Yadav, a tuberculosis survivor. Meera's very difficult fight with TB started with a misdiagnosis. And by the time she came to know she had the disease, it was very late.
So I was diagnosed in the year of 2012 and months. And I went to the hospitals. First, startedly, I was treated from the private hospitals, which took me around 2 to 3 lakhs. So I had a repeated treatment failure also. And finally, in the year of 2016, someone referred MSF clinic. And I went to the MSF hospital again, and I was diagnosing again.
Dozens of injections and oral medicines didn't work. Instead, they made it harder to cure her condition. Meera was lucky to have survived with new drugs, but the extremely drug-resistant tuberculosis took a toll. In fact, she had to have half of her lung removed. Like Meera, there are millions suffering with TB. Last year, India counted 24 lakh cases of TB. In 2018, the government took up an ambitious program to make India TB-free by 2025. Although a marked reduction is seen in new cases and mortality rates, the target is not even close to being met. So, in December, the government launched a 100-day TB elimination challenge to improve detection levels and treatments. While the idea for a TB-free India is a positive one, big gaps remain. So in this episode, we look at the realistic TB estimates with policy experts, doctors deeply involved in the issue, diagnostics maker Molbio, and Meera on how she won the battle against TB. It's Tuesday, the 21st of January. I am your host, Vikas Dandekar. This is The Morning Brief. Let's go back to my conversation with Meera.
So during my entire journey, I had to take a daily painful injections, 25 to 27 pills I had to take. And it was a very big trauma for me. Even I attempted 2 times suicide also. It's impacted my personal life, my professional life both. And finally, I got a right treatment from the MSF clinic with the newer drugs, and I got saved my lives.
So when you were misdiagnosed, what exactly was the treatment given to you? Which place was this? Was it a private institution? Was it a private hospital? What actually led you to be misdiagnosed?
So when I was diagnosed, that time I was completely unaware about TB, even the single word of TB. And I went to the private hospital. Firstly, I was treated from private hospital. It was a private hospital, where I was admitted to approximately 1.5 months. I don't know the private health practitioners, they using the technologies. Like I still remember only the CT scan and X-ray.
And then you said when you were on the multiple drug-resistant TB side, you were actually having more than 27 tablets and injections.
Yes, sir. Yes.
So where was this treatment? Was it in a government setup?
Yes. Someone suggested Shivri TB Hospital. It's the biggest hospital, and your treatment would be free if you go there. So I went there at the Shivri TB Hospital. Again, my treatment started over there in Shivri. And continuously 2.5 years, I was taking treatment from Shivri Hospital. But I don't know what was the problem. My treatment got failure. My treatment got MDR to XDR. Then Dr. Alpa ma'am was my doctor that time. And she suggested to go MSF clinic because my right lung was totally collapsed. And it is described in the CT scan.
So that was that part of the treatment was free, right? You didn't have to spend 3 to 4 lakh rupees for that, right?
Yes, but for the testing, for CT scan, for chest X-ray, or for blood test, I needed to pay that.
Meera's message is very clear.
My key messages is to early diagnosis and timely diagnosis very, very important for TB patient because it can become more resistant and it can impact to lose patient any part of body. So timely
So-
diagnosis, right diagnosis is very, very important.
But what kind of a progress have we made? Where do we stand in our fight against tuberculosis? And what is the way forward? That and many more in the following discussion.
Welcome all our esteemed guests to this very important ET Morning Brief podcast. We have a fantastic set of speakers drawn from diverse set of backgrounds. So quickly to introduce, I'll take Dr. Urvashi Singh first, Deputy Director General for TB from the Ministry of Health and Family Welfare. Absolutely distinguished work Dr. Urvashi Singh has done, and pioneering work also in terms of detecting viable TB bacteria in treatment failure patients, and a host of research work that actually has been done by her. We'll have Dr. Randeep Guleria, very well known as a former director at AIIMS and has been at the forefront across the COVID era that we had seen. Dr. Alpa Dalal, again, very well known name in pulmonary medicine, and she is also the honorary chief chest physician at Shivdi TB Hospital in Mumbai. And we also have Mr. Sriram Natarajan, Director and CEO at Mole Biodiagnostics. Thank you everyone for joining us for this very important discussion. So Dr. Singh, I'd like to start with you. We have this very ambitious program connected to elimination of TB, and it has been a much watched project also. There has been a decline in new incidences and mortality rates. Could you start by telling us how has been the journey so far and where do we stand in this very, very important and critical subject?
So, as you can appreciate, the decline has been something that has been seen as, by the global community, by the WHO Global TB Report as phenomenal. You see, we are a vast country. We are a developing country, having had made some major strides. Now, let me just allude to those major strides. The domestic budget for the National TB program has increased over 5 times in the last 10 years, meaning thereby India is the only country with high burden who can boast of 91% domestic funding supporting its TB program. Let me also allude to what strides we have made as far as the diagnostic networking is concerned. Now, this was so most of the world was dependent on one system. That was the Cepheid Gene Expert system. And we in India initiated the study in 2014 for TrueNat. And now, because of the domestic funding support and an indigenous technology, which gives us the same result as Gene Expert, we have more than 8,293 NAT systems under the National TB Elimination Program across the country. Which also brings me to the strengths that we actually have within the country is to diagnose not only TB along with drug resistance to rifampicin. We are coming up with several newer diagnostics and point of care diagnostics for drug resistance detection to other drugs which are important to us for treating TB, which again is a first for our country. We have a wonderful network of X-rays across the country, fixed X-rays. We will soon have X-rays for screening, which can go door to door and screen our vulnerable population. So in our 100-day campaign, the prevalence survey report conducted by the National TB Program, along with ICMR, brought out that 80% of our TB burden is in the vulnerable high-risk groups, which includes diabetics, people living with HIV, those who are old age, smokers, alcoholics, those who have had TB in the past, and a group of low BMI, which contributes to about 46%. Our country research highlighted that patients with TB recover better if they're given nutrition support. Household contacts who are low BMI are have more chances of getting TB. risk groups like mining community, those who are exposed to silica dust, silicosis, tribal areas which are difficult to reach, and, who do not really access the healthcare facilities. All these and several more add to the high risk groups. So what we are offering in the campaign is we are screening every high risk group with an X-ray, the only approved tool. Moving on to confirmation by a nucleic acid amplification test, which became a household word when COVID came along. And like I said, our strength to diagnose is very good.
Dr. Singh, you spoke about access to vulnerable groups and they being facing the biggest problems. If you can take us through the deterrents in this entire program, what exactly are those and how do we intend to change the situation?
The only deterrent to our moving forward is the health-seeking behavior of our population. Again, something that has been highlighted by nationwide studies. Even, in fact, the prevalence survey also brought out the subtle symptoms of TB. I use the word subtle because there'll be low fever, there'll be gradual weight loss, there'll be anorexia, there could be evening rise in temperature, there could be night sweating. So these are issues which are keeping. The other things that is keeping patients from approaching the health system is the stigma associated with TB. So these are two things we need to actually change in our population, make the knowledge of TB common knowledge, make the knowledge of symptoms that one should be looking for. We have moved on from 4 symptoms to 10 symptoms. And, we urge all our high-risk populations to come forth for at least a chest X-ray screening annually once in a year. We have the Nikshay Mitra initiative by our Honorable PM, launched by our Honorable President, where we offer nutrition support by the CSR to all patients and their families. Recently, we enhanced the direct benefit transfer amount from 500 to 1,000 rupees per patient throughout the treatment. And in fact, in the campaign, we are following a whole government approach. We have the line ministries lined up with us who are supporting in a big way. The Ministry of Health and Welfare is being supported by 22 different line ministries for awareness generation, for screening, for offering support to the patients. So all this effort, if it is done in the same fashion as we have designed in the 100-day campaign, we will definitely get there.
Wonderful. Thank you so much, Dr. Singh. That was a very comprehensive outlook. With that background, Dr. Guleria, can I come to you and ask where exactly did you see the bottlenecks?
So thank you very much for inviting me. And you're right, India has made a lot of strides and progress in terms of TB elimination. But I think we still need a lot to do, and there are a lot of bottlenecks which are available at the ground level. I think one issue is that all the treatment for tuberculosis now, as per the DOTS program, is free. But availability of drugs, and because of the stigma, sometimes patients don't go to the DOTS center. We need to sort of sensitize them, and the drug should be freely available. Sometimes you have a problem when you're treating drug-resistant tuberculosis, that at the local district tuberculosis center, sometimes availability of drug on a routine basis may become a little bit of a challenge. The other challenge is the treatment of tuberculosis is long. You need to take multiple drugs. It's actually for at least 6 months. And therefore, there is a loss of TB cases in the treatment cascade. And therefore, systems are making sure that they continue to adhere to the treatment protocol becomes very, very important, because sometimes patients come all right after, let's say, 6 to 8 weeks, and then they discontinue treatment, or the compliance is less. They decrease the drugs that they're taking because they feel that they're not needed right now and they're being overprescribed. So awareness among the patients about the importance of taking the full course of treatment, I think, is very, very important. We have made good progress in terms of being able to diagnose tuberculosis early, both in the form of screening with X-rays and the nucleic acid amplification test using the indigenously made kits, the TrueNAT. And that also has helped in early diagnosis. But it's very important that all these tools are available at a grassroots level so that we can find and treat all patients at the earliest. Finally, I think we also need to look at what we call latent tuberculosis infection, because there are a large number of patients in India who have what we call latent tuberculosis. They have tuberculosis which is lying dormant, and that can become active at some point in time. So there needs to be treatment strategies being developed to treat latent tuberculosis infection. And I think now there is also a big boost in terms of looking at tuberculosis vaccine, the TB vaccine, could also help in preventing the spread of disease.
Right. Thank you so much, Dr. Guleria. I mean, that's a fantastic physician's perspective. So, with that point, if I can go to Dr. Alpa Dalal and ask her, Dr. Dalal, you are right in the thick of action as a chest physician at Shivdi TB Hospital. The problem of multiple drug-resistant TB has been there for a very long time. And it really needed a lot of awareness, getting patients back on track. And a lot of those fatalities actually happened because of, patients not really adhering to the compliance standards. What has been your experience on that part? Have enough been done? What could be the trends to follow? Because that will hold a lot of importance if we are really to see elimination of TB in the right way.
Yes. It's a very, very important question, that incidence of MDR TB and what has been done. So me being in a unique position that I work in the private and the public sector also. So the challenges are that still we have sheer numbers, a large number of MDR patient being there. And the worsening resistance is a problem. And in drug-resistant TB, the treatment goes on for about 18 months, even with the newer regimen. So high dropout rates are common. Earlier, when we didn't have the newer drug, the treatment success rate was less than 50%. So we have large pool of patients who did not respond to the treatment. So all these patients add to the two problems, and that is worsening of drug resistance. And second problem is they get extensive lung damage. So all these patients, we have sometimes had to resort to, the salvage kind of treatment, and they need a lot of support in terms of hospitalization. And many times it so happens that even after treating them with adequate regimen and they getting cured in terms of culture getting negative, but still they are not able to live a normal life because they have extensive lung damage. So that is a big issue. There is a need for having more private-public collaboration, because even though there are a lot of progress has happened in the program, still we have about 60 to 65% of the patients who are treated in the private sector, who are diagnosed in the private sector. The treating physician in the private sector is still not very comfortable referring all their patients to the public sector, where they know that they will get best of the care and best of the drug regimen available in the public sector. And that leads to sometimes patient receiving inferior treatment, whatever combinations are available in the private sector, and also in terms of the cost. Another problem that we see is of human resource, and that is a real challenge in implementing the program guidelines, because of the stigma of working in TB sector. Many healthcare workers, including doctors and other paramedical workers, are not very willing to work with the TB patient. Plus, I think they should be probably get paid better, should be trained better. So I think for treatment of MDR TB, we need to have a little more comprehensive approach as to having newer drugs and salvage regimen available. And one more thing, we should have a good facility, indoor facility, where all care is available under one roof, including an intensive care unit and all other tests being available. And if these steps are taken, I think we would really improve the outcome for our MDR TB patients.
Thank you, Dr. Dalal. Thank you also for bringing up the points about strengthening the public-private partnership part. And we do have Mr. Sriram Natarajan, the director and CEO at Mole Biodiagnostics. Can I have Mr. Natarajan speak about his experience? Because you have very strong recognition coming from the most reputed names right here at the podcast about how TrueNat is actually transforming the way TB diagnosis has been happening over the last few years. Where do you think, Dr. Natarajan, we should go? Because, from the part of the government, there is also emphasis on going right at the village level for the detection of TB.
Yeah, you're absolutely right. So it is important that we are able to reach access to diagnostics to the grassroots level. I must say that the Indian government has been extremely proactive, and the National TB Elimination Program probably has been at the forefront of introducing a molecular test as a primary first-line test for TB. And in India, if my figures are correct, about 40% of TB testing as a frontline test is done by a molecular platform like TruNat. Whereas the global average still is only about 20-25%. So India is already leading this show, but there is still a big gap. We still have to look at the other 60% where people are still getting diagnosed by microscopy, where there is an issue about missing cases. We know that the Indian program under Dr. Urvashi Singh is already planning to ensure that this conversion to 100% will happen soon. And that will be a big step in terms of at least providing access for diagnosis. We also think that the private sector also has a role to play here. So we are working with a lot of institutions for that CSR funding, and they are seeing some early success. We already have some institutions like the IOCL and a few other private companies also coming forward. Now, Dr. Urvashi Singh just spoke about forward further from MDR to SDR TB diagnosis at the point of care. So we are already working. We already have a solution which is right now going through a validation. So again, we'll have a point of care solution which right at the first point of contact, you can know exactly what drug is going to work for the patient and give the appropriate drug. There's a lot of action happening as it is. And we really hope that in the next couple of years, things will change dramatically. And India will be the first country to completely convert to molecular test as a frontline test and completely replace smear microscopy.
All right. So I'll go back to Dr. Urvashi Singh now. Ma'am, you will want to speak something more to expand on the MDR TB issue. And then also with that, may I also request you to speak about the newer methods being taken up for early diagnosis of TB at the village level, if you can expand on that.
Right. Thank you. I would like to talk about MDR TB because that is something that, again, India contributes the maximum numbers. The reason why the MDR TB burden is high is, again, the health-seeking behavior. When a person who has had some symptoms or has had, TB for a long time, he could actually convert from a sensitive TB to MDR TB. If the person does not adhere to treatment, does not take his treatment regularly, does not complete the treatment, then he could turn to an MDR TB patient. Or sometimes a patient could actually get MDR TB from another patient. In COVID, there was so much awareness that every common man knew how the transmission happens, that you have to keep distance from a patient, 6 feet distance, and so on and so forth. The TB infection is in fact worse than COVID because it's not only the droplets that transmit the infection, but the droplets that dry up and form droplet nuclei, which can get suspended in the air, which was not in COVID. So this infection could actually affect the poor and the rich alike. The only vaccine, I've talked about this earlier, is the nutrition. We do not have an effective vaccine. The only recommended vaccine is the BCG vaccine, which is protective in our children. We protects small children against disseminated TB or neurological TB. Until such time we have an effective vaccine for the older population, the adults, the only thing available to us is good nutrition. So the dietary composition of our vegetarian diet could also be made up by dal, by nuts, by milk products, and so on and so forth. So it's important that the common man understands that good nutrition contributes to safety against not only TB, several other diseases, because it gives a good immune response. Now, as you may be aware, we got the shorter, more effective MDR TB treatment after I have taken over as DDG with support from the ICMR. The Health Ministry has been able to launch the BPAL-M regimen, which is a 6-month treatment regimen. And it is more than 90% effective. So Dr. Alpa talked about 18-month regimen, which was several years ago. We moved on to the 9-month shorter oral regimen, which in a very small percentage had to be extended to 18 months. Let me also talk about strengthening of the National TB Elimination Program. So Dr. Alpa mentioned about, centers where indoor facility can be provided like ICUs, etc. We have defined, in fact, centers of excellence for MDR TB treatment. Few are already there for the last few years. Few more are going to be, soon called as centers of excellence for MDR TB. Our district TB officers are also very well trained. And with the BPAL-M regimen, we've already had national level and zonal level trainings. And those who are not eligible for the BPAL-M, because if they have prior exposure to one of the second line drugs, only that small percentage will have to be put on the 9-month regimen, and a very minuscule percentage where there are issues that they're drug resistance to other drugs which are being used for treatment are then put on the 18-month regimen. So I'll repeat, a very minuscule percentage will go on to that. I think this is a misnomer that 66% patients are being diagnosed in the private. Let me say that we are offering free diagnostics and free treatment to patients who are notified in the private as well. And hence, this is a wrong statement that 60% get diagnosed in the private sector.
Thank you, Dr. Singh. Dr. Dalal, would you like to take it from there on? So you mentioned about the 18-month regimen. I think the new regimen comes into effect from November. So is there probably a quick switch that you would like to see?
Yeah, so I mean, I agree with Dr. Urvashi that a lot is being done in the program, but still we have to be aware that in sheer numbers, we still have a large number of patients whom we have to consider alternative regimen. Like for example, in Mumbai, we have highest number of fluoroquinolone resistant. So many a time that a shorter oral regimen, which is for 9 months, is not possible to be given, and then we have to give them the longer regimen.
Right. Also, Dr. Dalal, about new drugs that you spoke about. I mean, after rifampicin, I think the next one which we saw probably was bedaquiline, and then we saw another couple of drugs. We see the world talking so much more about weight loss drugs and the magic of GLP-1s. Taking over like into billions of dollars. Do you think there is a neglect to the treatment, or finding new innovations from global companies as well as Indian companies? Can something be bridged there as a gap?
Yeah, absolutely. So this TB specialist and chest physician always feel that the number of research and innovation that's happening in the field of oncology, that's way, far beyond what's happening in the field of tuberculosis. Because one, tuberculosis is a disease of the poor. It's been treated, it's a disease of the developed countries, and it's largely being treated in the public sector. So there is a neglect kind of thing from the industry to have more, funding for research and innovation. So that is definitely there. And having said that, you just talk about the obesity pill and, people thinking it's a magic pill. Same thing happens in tuberculosis also. So whenever any new drug comes or a new regimen comes, everybody starts thinking, oh, we found a solution. But TB being such a complex and comprehensive problem, and it involves, so many things, right from patient nutrition to compliance, the social issues, and the human resource and everything. I think a new drug or a new regimen can have a miracle only if complete chain is strengthened and all the issues which are responsible for TB being such a big problem are taken care of. And comprehensive solutions are only going to work, and not just any single drug or a regimen will solve the problem.
With that, I think we'll wrap it up, but not before we have a comment from Mr. Natarajan. Sir, as a private sector player, you've really done so much more in terms of getting new diagnosis, not just in India, across the world. What has been the change like for you, and what more do you think government institutions can do to actually spur innovations like TrueNat?
Yeah, just taking on from the last discussion, clearly, when it comes to infectious diseases, the major problem is in the developing world. So most of the developed country companies are not really very much interested in getting into this area because it's not a problem that they see in their countries. And they are much more happy to do work on cancer and on weight loss and so on. So that is why it's very important that we all have our own solutions, and India and other developing countries must be able to focus on enabling innovation to treat and to develop technologies for diagnosing and treating our problems. But of course, having said that, I must say that we had tremendous support otherwise from the government in terms of validations, in terms of even technical support. So that was primarily responsible for TrueNat to be developed as what it is today, as a multi-disease testing platform. I think private sector also has to play a role here. So I just wanted to say that we have started that process in our own company. We have an accelerator program called EDGE that we have started, where we are asking innovators to come to us, and we are funding them. We're also helping them through the process. And we hope that this will be one way of taking things forward. But there are a lot of capabilities in India. I think given the right kind of ecosystem, they can all be very highly innovative solutions going forward.
Thank you so much, Mr. Natarajan. That was a very important point that you made. And what I see from the comments of our experts is that there is a very, very clear, passionate appeal to see this, the improvement from where we are. So hopefully we'll have a far more better environment, a far more better healthcare system to take care of this major challenge that our country is facing. So thank you again for spending your time with us.
Thank you so much. Thank you.
Thank you.
So that was it. We had our speakers express their views on a bunch of issues. Hope you came out having a better view of the situation as much as we did. Thank you for listening. This episode was produced by Anirban Chowdhury and sound designed by Indranil Bhattacharya. Executive producers Anirban Chowdhury and Arijit Burman. The Morning Brief drops every Tuesday, Thursday, and Friday, wherever you get your podcasts. This is your host Vikas Dandekar signing off. Have a good week.